everyone, Assalamu alaikum. This is Dr. Tazeen, your mentor and course director at Study MRCPI, and we are here with another session of a free YouTube series for all MRCPI OSCE exam going candidates. And here we are going to have one structured discussion to give you an idea that how you have to perform structured discussions in the exam. I will be candidate, and with me Dr. Soumya would be examiner, and we will perform one structured discussion on antepartum hemorrhage. Hello, hi Dr. Soumya.
Hi, Tazeen. Thank you so
Thank you
much.
so much for your time. All right, so if you have not subscribed the YouTube channel of Study Medic, subscribe now and just click on the bell icon so that you can stay updated with the YouTube series, and just keep one thing in mind that you are capable, no matter how hard it is, no matter how hard it gets, you are going to make it. Keep your passion and dedication alive with you. So we shall start the session task. As you know that there is no reading time in MRCPI OSCE, so you have to quickly go through the task and then you will start. And meanwhile, if you feel that you need some information, the task would be in front of you on your table, and you can have a look again on the task, and then you can get whatever the information is needed for you. Hello, this is Tazeen, one of the exam going candidates. I have read the instructions and I'm ready for structured discussion.
Sorry, can you summarize the case for me?
All right, thank you so much for the question. So this is a case of antepartum hemorrhage where Mrs. Sarah Williams has presented at 34 weeks and 5 days of gestation in her second pregnancy with vaginal bleeding. This bleeding is painless and bright red in color. It is not associated with abdominal pain, and she reports normal fetal movement. Her previous pregnancy, she delivered through lower segment cesarean section due to fetal distress. And in this current pregnancy, on mid-pregnancy scan, there was low-lying placenta. So we may require careful maternal and fetal assessment for this patient for the ongoing safe management.
Okay. What is antepartum hemorrhage?
Antepartum hemorrhage is basically vaginal bleeding from the genital tract, which happens after 24 weeks of pregnancy and before delivery.
Okay. What are the main causes of APH?
Among the main causes of antepartum hemorrhage, there can be placenta previa, placental abruption, vasa previa. There can be local causes like cervical ectropion, some genital infection, tear or trauma or malignancy, or there can be unknown causes, or we can say that unknown etiology of antepartum hemorrhage.
Okay. So, for Sarah Williams, what do you think your probable diagnosis and can you justify?
The most likely diagnosis in Sarah Williams seems like placenta previa, as this bleeding is painless. So placenta previa is associated with painless bleeding. Also, it is bright red in color, which is also a feature of bleeding from placenta previa. And she also reports that in the mid-pregnancy scan that was low-lying placenta. So that is also among one of the risk factors. And her previous pregnancy was by lower segment cesarean section, which is again another risk factor. So the most likely diagnosis here is placenta previa.
Okay. What are the features which helps to differentiate between placenta previa and abruption?
In placenta previa, this is painless bleeding, while in placental abruption, it is associated with pain. The color of the bleeding is bright red in placenta previa, while it is darker color in placental abruption due to old blood. Fetal distress is more common in placental abruption, while it is less common in placenta previa. And also, uterus is soft and non-tender in placenta previa, while in placental abruption, this is a diagnostic feature clinically that there is tense, tender, woody, hard abdomen.
Okay, let's come back to Sarah Williams. Now you know the scenario. What is your initial assessment and management?
Based upon the clinical scenario, as she has presented with moderate bleeding, which is fresh, bright red in color, so the resuscitation and management of this patient would be simultaneous. So first of all, we will make sure that this patient's airway and breathing is secured, and if needed, oxygen should be given to this patient. We should check the vitals of this patient, and 2 wide bore cannulas should be secured, and blood should be taken for blood group cross match, full blood count, coagulation, renal function tests, and blood bank should be informed about the arrangement of the blood. Fetal well-being should be assessed through continuous electronic fetal heart rate monitoring, and also a blood loss should be estimated, as in most of the cases of antepartum hemorrhage or postpartum hemorrhage, at times the blood loss is underestimated. So we should be very careful about that, and digital examination should be avoided until we are sure about placental localization.
Okay, how do you manage her now?
The
The first
management of this patient the management of this patient would be by a multidisciplinary team. Multidisciplinary team should include senior obstetrician, then anesthetist, hematologist, intensivist, senior midwife, as well as neonatologist. And we should make sure that the cots are available in the neonatal intensive care unit, as she is at 34 weeks of gestation. She needs immediate admission in the intensive care unit, as she is having moderate amount of bleeding. And the management of this patient after completion of all the baseline investigations, which are blood group cross match, full blood count, renal function tests, and coagulation screen, we should also perform ultrasonography to check the fetal well-being as well as placental localization. And then if the patient is stable, we can do the conservative management. If she is bleeding and her blood group should be knowing, and if the need arises and she is Rh negative, NTD should be administered. As she is 34 weeks, so steroid covers should be considered for lung maturity. Patient should be counseled regarding diagnosis and its feto-maternal implications. She should be reassured that support is available and best management would be provided to her. And also, she should also be counseled regarding the need of blood transfusion, recurrence of this condition in the next pregnancies, as well as this counseling should be done. And if the bleeding continues and this is placenta previa, then she may need emergency cesarean section. And also in case of placenta previa, if she is stable at the moment, she may need elective cesarean section at 36 to 37 weeks of gestation.
What are the factors which helps you to decide whether you want to deliver her now or later?
Patient's stability is most important feature which can decide that whether we have to go for immediate delivery or we have to go for conservative management. So feto-maternal well-being should be ensured. If there is ongoing heavy bleeding, if maternal hemodynamic instability is there, or fetal compromise is there, we are suspecting placental abruption, or the labor starts with placenta previa, then we should go for immediate delivery.
Okay, thank you. That finishes my questions.
All right. Thank you so much.
Yes, I think it's a well done station. The few things which I really liked was MDT and NICU, because those are important. And of course, because most of the thing as MRCPA, they always ask a lot about the theory part. I think that was managed well as well. Well done. Thank you.
So much. Thank you so much, Dr. Somi. Thank you. All right, so this is a station of antepartum hemorrhage, which can be asked in the exam. So you should be knowing that how you have to take up this structured discussion in the exam. Candidate instructions are given to you. So just quickly, you should have a look at the candidate's instructions. You can take 40 seconds to 1 minute to understand that what actually the clinical scenario is, so that you can answer the examiner appropriately. So here Mrs. Sarah Williams is in her second pregnancy at 34 weeks and 5 days of gestation, and she has presented with vaginal bleeding. Now the features of bleeding are very important. It is painless bleeding, which is giving you a clue that this can be placenta previa, which is associated with vaginal painless bleeding. It is moderate in amount, which means that she needs admission, and this cannot be ignored. It is bright red in color, which is again another feature of placenta previa. No abdominal pain. Fetal movements are normal, and previous pregnancy she was delivered by lower segment cesarean section due to fetal distress. So basically, from the candidate's instructions in the structured discussion, you have to pick up the risk factors, that what are the positive findings or important findings are given to us. And then at 20 weeks pregnancy scan, that was low-lying placenta, which is also another important risk factor, that this can be placenta previa. So now moving forward to that, this patient is in her second pregnancy, how the case presentation is. Presenting complaint is sudden onset of painless vaginal bleeding, moderate, bright red in color. Key points in the history is that she had previous lower segment cesarean section, and it is low-lying placenta at 20 weeks scan. And the current status is that the normal fetal movements, vitals are stable, and no abdominal pain is there. So we should understand antepartum hemorrhage by knowing its definition, that what is antepartum hemorrhage? Bleeding from or into the genital tract, which occurs after 24 weeks of gestation and before delivery. The main causes can be placenta previa, placental abruption, vasa previa, local causes like cervical ectropion, infection, malignancy, trauma, or unexplained antepartum hemorrhage can also be there. So the most likely diagnosis, now the risk factors which are given in this scenario, you will pick those risk factors and you will reach the most likely diagnosis. This is painless bleeding, which is the classic presentation with no abdominal pain for placenta previa. It is bright red in color. Fresh bleeding indicates active hemorrhage. Low-lying placenta on the 20 weeks scan, that is again indicating that this is placenta previa, and the previous delivery was by a previous cesarean section, which is again a significant risk factor for placenta previa. When we have to differentiate that what are the differences between placenta previa and placental abruption, bleeding is painless in placenta previa and it is painful in placental abruption. Uterus is tense and tender in placental abruption and it is soft, non-tender in placenta previa. Fetal distress is common in placental abruption and fetal distress is less common in placenta previa. So placenta previa presents with painless, bright red bleeding, soft uterus, while abruption causes painful, dark bleeding with tense and tender uterus. And most of the time in the scenarios, basically woody heart abdomen, woody heart terminology is used when describing placental abruption. Now this patient has presented with moderate amount of bleeding, so resuscitation as well as management of the patient would be simultaneous. Resuscitation again is our ABCD approach, that we have to make sure that airway and breathing is secured, and if the need is there, oxygen should be given to the patient. We have to check the vitals. 2 large pore IV cannulas should be secured. Blood should be taken for cross match, full blood count, coagulation screen, and other investigations. And blood bank should be informed about blood arrangements. Fetal distress should be assessed by, and fetal well-being should be assessed through continuous electronic fetal monitoring, and blood loss should be estimated correctly, and digital examination should be avoided until we have definitive diagnosis that this is placenta previa or some other cause is there. Essential investigations always in the cases divide the investigations, that some are the baseline investigations and some are the specific examinations which are particular to for that particular case. And also in antenatal cases, always remember that you have to ensure maternal well-being as well as fetal well-being, so don't forget about the baby as well. Laboratory tests will be full blood count, blood group cross match, coagulation screen, and Klehor test if Rh negative patient is there, and imaging and monitoring for localization of placenta as well as for fetal well-being we have to do, and also continuous electronic fetal monitoring should be carried out. The management plan would depend upon the hemodynamic status of the patient. If she is stable, we can admit the patient under observations, as this patient has presented at 34 weeks with moderate amount of bleeding. Always remember that who all will be involved in the management of this patient. So multidisciplinary team involving senior obstetrician. We have to involve hematologist, as the patient is bleeding, she may need blood transfusion. Blood bank should be informed about the blood arrangements. She's 34 weeks pregnant, so for the fetal well-being, neonatologist should be involved. Senior midwife should also be there, and if she needs a cesarean section, anesthetist should also be involved for this patient. If she is Rh negative, anti-D should be administered as she is 34 weeks, so fetal lung maturity should be ensured and steroids should be given, and elective cesarean birth should be planned at 36 to 37 weeks if it is major placenta previa. The indications of immediate delivery is basically emergency protocol, that immediate delivery is indicated when conservative management poses greater risk than preterm delivery. Multidisciplinary team involvement is essential. So what are the situations where we have to go for immediate delivery? That can be labor with placenta previa, if the hemodynamic status of mother is unstable, ongoing heavy bleeding is there, suspected abruption is there, or fetal distress or fetal compromise is there. Any of these scenarios, it requires urgent intervention to protect maternal and fetal well-being. So how we have to counsel the patient? The first thing is that patient is worried that what has happened. So she should be counseled regarding the diagnosis, that what actually has happened and what can be the feto-maternal implications. The next question, whenever we are disclosing the diagnosis to the patient and we are discussing the diagnosis with the patient, they always ask that why this happened. So you have to tell in a very sensitive way that what can be the causes of this vaginal bleeding. Delivery planning is very important, as the patient might be very worried about the baby. So discuss the mode and timing of delivery. Likely cesarean section may be needed. Risk awareness should be done in a very sensitive way. Risk of recurrence, need of hospital admission, need of blood transfusion, and if she is discharged after conservative management, if any further bleeding is there, so she has to report to the emergency as early as possible. Baby's well-being is also very important, so neonatal considerations should be considered. Discuss prematurity risks with the patient, and also ensure that neonatal care is available for this patient. This is how you have to tackle structured discussions in your exam, and I hope this session will help you for your exam preparation. And we at Study Medic wish you all the very best for your upcoming exams. If you have not subscribed YouTube channel of Study Medic, subscribe now and stay updated with the upcoming sessions. Thank you so much.